This talk will be about evaluation and management coding specific to interventional radiology as it pertains to the inpatient setting. This will be a two-part series. This topic will discuss inpatient E and M coding. The subsequent video will cover outpatient E and M coding with the new 2021 updates, which I'm very excited about. Myself, I'm an interventional radiologist. I practice 100% interventional radiology. As I entered into practice, I was in a mixed diagnostic and IR group. We separated from that group 2 years ago, and I'm in a large IR only group. When we made that break, I became the point man for E and M coding, something which, coming out of fellowship, I really knew nothing about. So I took it upon myself to sort of self-educate, and I found really for the physician to learn about E and M coding, there's not a lot of resources out there to fill in the gaps to make it where you feel confident going out and billing for these services. So SAR website, they give you some tools, but again, I don't think it fills in the gaps to actually go on the floor and document a note. So the purpose of this talk will be to fill in those gaps. What I want to do is provide information so that when you go out and you build these clinical encounters and you document these, that you feel confident in knowing that you're doing the right thing, that you're picking the right charge. We are all, or most of us, are already doing the work. This is just going to be a bare bones approach on how to document the clinical encounter so that you can bill for that service. To that end, and I think one of the most important parts of this is to have a reference. So I have made 2 handbooks, one for the inpatient E and M coding and one for outpatient E and M coding. Though that handbook for the inpatient E and M coding is going to be linked below the video. It is very important that you print this off and use it as a reference throughout the talk. It'll be very helpful. I have these printed as pocket books. Again, one of my residents, Noelle Lafitte, she helped me prepare those books. You can share this with all your friends. You can print it. I don't care what you do with it. I want people to use this as much as they can because I feel like I'm just trying to fill in the gap for something that as interventional radiologists we should know more about. If you like the channel, please subscribe. Please like the video. If you have questions specific to E and M coding, please put that in the comments and I will try to reply, and that way everybody has access to it because most of us have the same question. So I think moving forward, that'll be very helpful in the future as people watch these videos. So why add E and M to your interventional radiology practice? I think the most important reason would be that it is improved clinical care. When a patient comes to my service, let's say for example for a abscess drain, I'm going to put that abscess drain in, and then every post-operative day I will see them in the hospital. Things we will do is I'll teach them how to flush their drain. I'll give them drain care supplies because you can't go to Walmart and just buy flushes, and even some pharmacies it's hard to get. And then I will sort of instruct them on what I anticipate the follow-up to be. If you look at any other surgical service, like let's take urology for example, my twin brother's a urologist. If his patient comes in to do he does a PCNL on that patient or whatever, he's going to see them every hospital day following the surgery. And I think it's crazy that we have interventional radiologists out there that don't do the same. That's just my opinion. Also, I think it really ups our hospital presence. In a typical day, I'm going to round on all my inpatients. I'll hit most of the ICUs and most of the floors. And while I'm doing that, I'll see a lot of surgeons or referring providers. And if you take 2 interventional radiologists, you take one that doesn't do any inpatient E and M work, doesn't round on any patient, and you compare that to a physician that does, I do think it's significantly better clinical care from the patient's perspective. But if you look at it from the referring physician's perspective, they're going to see me every day rounding on that patient. And that is perceived better clinical care. And so I think interventional radiology moving forward needs to adopt this clinical model, 100%. Some of you are still in mixed IR diagnostic groups, and you may have to sell this, which is crazy. But if you're going to sell it, it is increased work RVU revenue. If you look at inpatient E and M work, anybody can do that. And so those are work RVUs that you're leaving on the table because there's no overhead added to adding that work RVU revenue. Now, when you look at an outpatient practice, there's a significant amount of inputs from a money side to get that clinic up and running. If you want to start an outpatient clinical practice, maybe you ramp up your inpatient IR E&M work for 6 months, use that to justify the added expense of an outpatient clinic. That's just my thoughts. Number 3, it offers you legal protection. So if I'm working on the weekends and for some reason I have an abscess that I don't feel like there's a safe window, I'm going to go down in the ER and I'm going to see that patient and I'm going to put a note in and I'm going to use the snipping tool, which I think is money. If you haven't used it, I'd recommend it. And I'll actually snip pictures of the CT and I'll explain why I don't see a clear window. But then it's in the chart, in the record, why interventional radiology can't drain that abscess. Time and time again, people don't go up and see consults, and we're all busy, but it really boils down to just being lazy, not doing the extra steps to go see the patient. And there won't be a note from IR, and then the hospital will just say, IR refused. And they don't ever say why IR refused, or sometimes it's incorrect. But this way, it's in the chart why you refused. So this slide is from a prior SIR presentation. I apologize for not having the link to it. This came out in 2016, 2017. I can't find it, but I think it's a pretty good evaluation of E&M services. So if you look on the right, percentage E&M services, interventional cardiology, like 40+%. Vascular surgeries, right at 20%. IR is horrible. We're 1 to 2%. That if you look on the left, again, you look at evaluation and management coding. Invasive services were the majority. Diagnostic services were about 34%. And then E&M only is at 2%. And so my question was, 2 years ago when we started with the IR only group, was would my E&M coding be 20%? I knew it wasn't going to be more than 20%, but my goal was to see if I could get it close to 20% because I feel like that's where most IRs could be. So this is my first year as an independent IR. So 8,204 work RVUs total. That's IR only. I feel like IR only work RVUs are really hard to get compared to diagnostic work RVUs, but that's my total. So my first year, I had 13% of my billing or collections came from E&M coding. And if you look on the right, what percentage of that was inpatient work? Well, 94%. So can you get a significant chunk of your work RVU production from E&M? And I think this proves that, yes, you can. And can you get it from inpatient work? Yes, you can. We are working on an outpatient clinic, but don't have one up and running. So that's why most of my E&M work comes from the inpatient side. Here's some examples of work RVU values, E&M versus procedural. You can see a biliary drain change is 2.61. That's the same as a level 2 admission. And you can see some of the stuff on the right, everybody's like, oh, kyphos are big work RVU producers, but so is some of these E&M things, right? So a level 2 inpatient progress note is 1.39 work RVUs. If you round on 8 to 10 patients a day, you come in at 0,700, you round on 8 to 10 patients, which is feasible, then you're looking at starting the day off with already 10 to 12 work RVUs. A couple tips for beginners, because those of you that aren't doing E&M coding, the most important thing is to be efficient. And the number one way to become efficient is to use templates in Epic. That can save a lot of time. So what I did, there's an auto text editor or smart phrase editor in Epic, and you can go in there and you can, at least at all the hospitals I've ever worked at, which is 3 that have Epic, you can search through other people's templates. And so I just went, I found a couple of urologists that I think have good notes, and I just stole their templates. And so those templates auto-populate everything, vitals, labs, past medical history. It makes the note pretty long, but again, it auto-populates all those things, so I don't have to go in and fill in the gaps. Number 2, as you get started dropping charges, it is very important for at least the first 6 months to have an open line of communication with your billers And what I did with my billers was I said, well, if you're going to upcharge a note or you're going to downcharge a note, you let me know and you let me know why. And that was very, very informative. Number 3, and this is huge, use voice dictation software. So don't sit there and type. That is way too time consuming. Most people with Epic at their hospital either have dictaphones on the computers, or like at my hospital, I have an app on my iPhone. So I do all my dictations off my iPhone mic. So it is, again, very, very efficient. As we move forward through this coding talk, as it pertains to inpatient E and M coding, I am going to focus on 3 to 4 main codes. And I encourage you to focus on 3 to 4 main codes because, again, you have to remind yourself, these E and M codes were made for family medicine doctors too. So we don't live in the low-level codes. Most of our patients are really, really, really sick. And so we can bill, for most of our stuff, we're billing higher level codes. And I'm going to go over that with you. How hard is it to drop a charge? So this is just a screen at my hospital of what it looks like when I'm going to drop a charge. So right where that arrow is, where it says search for new charge, I'll just type in whatever that charge may be. For example, 99283, and then I just hit add and save, and that's how I drop charges. So it doesn't have to be this time-consuming process. Some people who work in a private group, when I was in the private group, we used to just have cards that we would circle whatever the charge was, put a patient sticker on there, and then we would return that in. So it doesn't have to be that difficult. I think this is one of the most important slides that we're going to talk about today. Globals. So what is a global period? Global periods are periods after the procedure, so post-operative day 1, where you can or cannot bill E and M services. Most of the stuff that we deal with in interventional radiology has no global. So previously, years ago, they dropped payment for a ton of our procedures. We got thrown under the bus, and they whacked off the E and M. They whacked off the globals. So they said, well, we're not going to pay you as much for this procedure, but we're going to take off the 10-day global. And so what the thought process on that is if you go and you do the post-operative day 1 through 3 and you bill the E and Ms, it would be the same amount of work RVUs total. So if you're a urologist, kind of that makes sense. But interventional radiologists, they don't do E and M coding on the inpatient side like a urologist does. So I'm just trying to explain why we don't have a lot of globals. So 90-day global, unless you're doing carotid stenting, that's it. So nothing's a 90-day global. And then we have 10-day globals. There are 5 things on a 10-day global. You have kyphoplasty, central venous access, cholecystostomy, gastrostomy or gastrojejunostomy tube placement, the initial placement, and then any ablation. So it's 5 things. And if you do those 5 things, post-operative day 1 through 10, you can't bill any E and M services. And then everything else is a 0-day global. So every single thing else that we do, if I didn't just talk about it at 10-day global, then you can do inpatient progress notes on those patients, and you can bill for them. When you look at my clinical service, if I have a inpatient kyphoplasty and let's say an inpatient abscess drain, my notes are going to be 100% the same, and my clinical care is going to be 100% the same. So from my clinical service standpoint, I just know that I'm not going to be able to bill for the kyphoplasty, but the service rendered looks the same. One question I get a lot of is if I see a patient the same day that I do a procedure, can I bill for that clinical encounter? And the answer is yes, you can. Now, I only use this in certain situations. And so the situations in which I use this are patients who are critically ill. And my thought process is if the patient is sick enough for me to come in at night to do the procedure, or I feel like I need to go see them and evaluate them on the day of the procedure to see if maybe they need anesthesia or they may or may not be a candidate for moderate sedation, I'm gonna pop this modifier 25. But I am very clear in my note as to how I do it. So the first thing I will say is patient was evaluated in the ICU. So at that point in time, I'm documenting that I didn't see them in the IR department. And then it has to be significant and separately identifiable. And I'll say the significance of why they were seen was I wanted to evaluate, would they be a candidate for moderate sedation? Can they protect their airway? And I go through the list of kind of what I'm looking at. You know, do they need to be on pressors? Do they need vascular access? At my hospital, a lot of times at 2 a.m, I'm the one that's doing all those things. And then number 2, it has to be separately identifiable. Well, that's pretty easy. I just put in a consult note. And then when they come down for the procedure, I'll put my normal pre-procedure note. So again, in my note, I've documented the significance of why I am seeing and evaluating the patient. I'm saying where they're being evaluated, and then it is separately identifiable because it's separate from my preoperative note. And I think I just use this on stuff where I do think evaluating the patient in the ICU with sepsis is above and beyond, let's say a nephrostomy tube, for example. That's above and beyond the normal routine clinical work that you would do for, let's say, a nephrostomy tube for PCNL access. But again, this is something that kind of is a topic of debate. On the modifier 25, this is a good one to go back and forth with your billers to make sure that you're capturing this charge appropriately. So how do I level a note? And we're going to talk about medical decision-making ad nauseum throughout the rest of this encounter or rest of this presentation. So medical decision-making will drive everything that we do in E and M coding. So once I've calculated the medical decision-making, which is the most complex part of this stuff, then all I have to do is find the code that fits with that medical decision-making, that level of medical decision-making. And then I need to perform and document the minimum physical exam and history required for that code. And that way you could be as efficient as you need to be. There's no point in doing a comprehensive physical if it's not required. There is component-based billing and time-based billing. We will briefly touch on time-based billing, but I can tell you that I only use time-based billing in certain scenarios. There are 95 guidelines and 97 guidelines. We will use the 95 guidelines throughout the remainder of this talk. I will never reference 97 guidelines because they are more detailed than the 95 guidelines. So let's just use whatever is the most simple, which is the 95 guidelines. Time-based billing. This will be the slide on time-based billing. So the inpatient guidelines are time needs to be spent face-to-face with the patient or on the patient's floor. So on the ICU. So if I'm going to work on reviewing clinical documents, if I'm in the ICU with the computer open up, that counts. Half the time needs to be spent in counseling and coordination of care. You document the time in your note. And then here's my little blurb I put in there at the bottom. You can see I only use time-based billing in scenarios where I feel like time is a driving factor. So for example, Friday, I spent 45 minutes on my morning rounds talking to a patient about de-escalation of care, hospice and palliative care. And so I use 45 minutes to drive that note because that 45 minutes was more than I would usually use. So otherwise, where it's not a really time-consuming clinical encounter, I will opt for the component-based billing. There are 3 key components to leveling an E and M encounter. There's history, examination, and medical decision-making. And like I said earlier, medical decision-making, which is the complex part about E and M coding, is what we're going to spend the majority of our time focused on. And again, there is a PDF handbook that is linked at the bottom of this video. Please print off that handbook because I'm going to reference directly from there. And what I want to do is sort of explain the handbook, and then as you go around, you'll have a reference to look at. When we look at medical decision-making, there are 3 things that drive medical decision-making: diagnoses, data reviewed, and risk. And risk has a big chart that we're going to go over. You need 2 of the 3 to level your note. So for example, let's say I'm doing a inpatient progress note. And for medical decision making, it's moderate. And I'm going to need moderate data review and moderate risk. if my diagnosis and treatment options don't hit that level, I will still be able to bill for that medical decision making. So again, with medical decision making, we have diagnoses, data, and risk. And so when it comes to diagnoses, these problems are relative to the physician, which is important. So most of our patients come, if you look on Epic, I may have a patient that comes to me and they've got hypertension, diabetes, high cholesterol. All of those things count. Even if they're established problems, those problems are considered new to me, as this is the first time I'm seeing this patient. You can also count stable problems that you are not directly managing if, for example, those problems increase the complexity of your procedure. So if I put a nephrostomy tube in a patient and I'm seeing them on day 2, let's say they have bladder cancer, type 2 diabetes, hypertension, even though I'm not directly managing the cancer, I'm not directly managing hypertension, diabetes, all those things make my postoperative recovery complex. So I can bill those as diagnoses, as stable diagnoses. This slide is the first reference to the handbook, and this goes over diagnostic points. When we look at different levels of notes, for example, the highest level note that we can get for medical decision making will be high complexity. That only requires 4 points off of this number of diagnostic and or management options. So let's take a normal patient that I've had recently. Let's say comes in with renal failure, creatinine of 5, bladder cancer, and has hypertension, diabetes, needs a nephrostomy tube. So again, it's a new problem. Additional workup is planned. That's 4 points on there. And I've already reached my high complexity, but the patient will get multiple other point things, right? So the bladder cancer, new problem, no additional workup. That's 3. Established problem that's stable. That could be the hypertension, the type 2 diabetes. And so we're already at 9 points. So it's, again, these playbooks are designed for family practice doctors. And so for the interventional radiologist who deals in an arena of very sick patients, this is a very easy box to check. After reviewing diagnoses, then we look at data. And when we look at the difference between a moderate complexity and high complexity, just like with the number of diagnoses, a high complexity is only 4 points. A moderate complexity is only 3 points. As an interventional radiologist, one of the things we can do in this section is an independent review of image, tracing, or specimen. So if you look at the very bottom, you can get 2 points for saying in your note, I independently reviewed the CT abdomen pelvis dated X, and it shows moderate right hydronephrosis and large obstructing bladder tumor. So you just put your, the key thing is to say that you independently reviewed. And again, just use the language that they use, right? It says independent review of an image. Say I independently reviewed the image, that's 2 points. And then if you review and or order clinical lab tests, that's 1 point. If you review test on a day and order lab tests, you don't get 2 points for that, you just get 1 point. If you order a chest x-ray, that could be a point. And as we go through this, discussion of test results with performing physicians. So if you talk to the hospitals, you talk to the intensivist, that's why people will document that in the note. I discussed this with Dr. Such and such, and that they do that because that's a point. The third thing I'm going to talk about, so we've talked about diagnoses, we've talked about data, and again, all these are in your handbook, so please, please, please print the handbook, is risk. And this is looks like a very busy chart, but we're going to focus on just a few things so we don't complicate it. I've bolded the things that I typically fall back on. You only have to have one of these categories to qualify. So there are 3 categories in this chart. There's presenting problem, there's diagnostic procedures ordered, and there's management options. So the middle column, diagnostic procedures ordered, we're typically not going to be in that column. It's either management options or presenting problems. If we look at the far column to the right on management options, we have to look at what do interventional radiologists do. And it's important to know the difference between a major surgery and a minor surgery. So a major surgery is anything with a 90-day global. A minor surgery is anything with a 0-day global or 10-day global. So we just do minor surgeries. So if you have a minor surgery with a risk factor, which is like all of our patients, because we're not doing, I'm not over here doing breast implants. I am dealing with very, very, very sick patients. So that automatically will qualify you for moderate risk. If we slide on over to the far left chart, you look at presenting problems. So if you have greater than 2 stable chronic, that gets you moderate. If you have an acute complicated injury, that gets you moderate. I mean, an acute illness with systemic signs and symptoms, so your typical septic stone with urosepsis, most of our patients will follow in this moderate risk category. One of the things where you can look to see to upswing you on the high risk category, if you talk about DNR de-escalation of care, or if you have abrupt change in neurostatus. So I perform stroke, thrombectomy, and that factors into some of the billing that is associated with those services. So we've gone over all these things. So problem points, data points, and risk. And now we have to calculate the medical decision making, because the medical decision making will then drive the HPI and the physical exam. And again, you only need 2 of the 3 elements to level the medical decision making for the encounter. So for example, if I have moderate complexity for a note, then I only have to have moderate complexity for problem points and data points. If my risk is minimal, but I've got the data points and the problem points, then I can level it out for medical decision making as moderate complexity. Now we're going to talk about history. When it comes to history, there are 4 levels: problem focused, expanded problem focused, detailed, and comprehensive. The components that go into history are HPI, review of systems, and PFSH, which is past medical family social history. So if you look at HPI, if you look at the upper right-hand corner of that chart, there are 8 things there. Location, quality, severity, duration, timing, context, modifying factors, and associated signs and symptoms. So when I think about somebody who on the billing side of things is going to review my note to look for these points, it's very easy for me to dictate an HPI, which they can harvest the points out of it. So let's say I got somebody with cholecystitis. I'm going to say, and it's a comprehensive history. All I need is 4 things, right? So the location of the pain is in the right upper quadrant. The quality is described as intermittent, worse with eating. Severity is 9 on a 10 scale. Duration is 8 hours. And there are no associated signs and no other associated signs and symptoms outside of fever, etc. So I've already hit 5 points, but I just used, the point of it is I use their words. So I will say the location is, the quality is, severity is, and that may seem very simple, but it makes it easy for them to go back and calculate up the points. If we look at review of systems, again, for example, if we go to a comprehensive history and we swing over to review of systems, we can see that we need a complete review of systems. So we need 10 things. So again, we talked about trying to make your life easier, auto-populating all these notes. My template automatically populates 10 review of systems. And if I'm seeing a consult, again, I'll try to go through those review of systems. PFSH, again, there's on the right bottom hand corner, we can see all the different things. So on, for example, a detailed PFSH, we just need pertinent to one area. So if you're biopsying somebody for a lung cancer, for example, it may be important to talk about their smoking history. If you're going to do a comprehensive, then you've got to do a little bit more extensive PFSH. Most of my patients, though, in my hospital have seen somebody else, and this stuff all auto-populates. So the only thing I'm really worried about is HPI. And I know the 8 things that are associated with HPI, so do not get scared about this history component, because again, all of this is almost auto-populated. Obviously, you're going to have to fill out review of systems, you're going to have to fill out HPI, but PFSH should already be in your system. Physical exam. There are 4 categories of physical exam: problem focused, expanded problem focused, and detailed comprehensive. I wish they would just label these 1 through 4, but they don't. And you can see I've outlined what you need for a comprehensive versus a detailed. So one thing to note is comprehensive is 8 organ systems. So in my note, I just have 8 organ systems auto-populated. One thing I do want you to know is if you auto-populate 3 separate vital signs, heart rate, blood pressure, and temperature, whatever, 3 vital signs, that counts for a constitutional organ system. So then if you're going to go through your note and it's a comprehensive physical exam, you only need to talk about 7 different organ systems. You can see in the organ systems boxes what there is to choose from. Now we're going to talk about the actual codes. And again, all this stuff's in the handbook for easy reference. But I'm going to tell you how I use these codes and when I use them. And then at the very end of the talk, we'll have a couple clinical scenarios. But I don't want to get too bogged into the details. So the admission H&P, I think this is an underused code by interventional radiologists. Obviously, if I'm going to admit a patient to my service, then I would build this code. But 9 times out of 10, I'm not admitting a lot of patients to the hospital. If I am, it's typically procedurally related for ablations, etc. Where this code can be used and where I use it is if I have a patient that I see in the hospital, for example, let's say it's very obvious this patient needs a nephrostomy tube and I'm going to put in the nephrostomy tube the next day. I can go up and see that patient and I can bill 99222 typically because it'll be a moderate medical decision making, and then I'll make my exam and history comprehensive and I can bill this. Even if they're, let's say for example, they've been there for 3 days. If this is the first day that I see that patient, I can bill an admission H&P. And even if a patient comes to the hospital and they see 10 providers on their day 1, all 10 providers can bill 99222, assuming they're different specialties. And then one of those providers will be designated as the primary provider. So again, we will talk in the future in a couple slides about consultation codes. If I feel like that the procedure is obvious and needs to be done, I'm not going to build a consultation. I'm not going to build a consultation code. I'm going to bill 99222, which is listed as admission H&P, but really for me, it's hospital day 1. Now we're going to move on to inpatient progress notes. These inpatient progress notes can be billed on any patient post-operative day 1 through infinity. So assuming that you're providing relevant clinical care to the patient. Any patient that has a 0-day global, you can bill an inpatient progress note. And just to go back over it, the 5 things that have a 10-day global, which means that 10 days after the procedure, you can't bill one of these inpatient progress notes, are kyphoplasty, central venous access, ablation, gastric access, and then the oddball cholecystostomy tube placement. So those things all have a 10-day global. I will still go see those patients. I will still put in notes, but I cannot bill these codes on those patients. This is the bulk of your inpatient practice right here. And when we look at these codes, you've got levels 1, 2, and 3. So level 3, that's like a patient that you need to escalate care. So most of our patients that necessarily doesn't apply to, right? So if I look at that code, like if I'm a hospitalist and I got to kick my patient into the ICU because they've had an MI or something, that's a level 3 note. The times where I will bill a level 3 inpatient progress note are time-based. So like I was saying before, like let's say I got to do a de-escalation of care or a DNR talk with a family and it takes 55 minutes, then I'm going to bill that 99233 and I'm going to bill that based on time, even though from a component standpoint, it was probably a 99232. And one thing I want to be clear about, when it comes to component-based billing or time-based billing, it's an or thing. So I may bill a 99232, but I may only spend 10 minutes with that clinical encounter. I don't have to spend 25 minutes, and I just want to be clear about that. I've had some of my older partners in the practice that were like, well, I don't think I can bill for that because I didn't spend enough time. And that's not what it's for. Time is basically put in there so that if you spend an inordinate amount of time for something that's not clinically that complex, you can capture that time. So for 99232, the important deviation from other E and M coding is you only need 2 of the 3 key components to qualify. So for like an admission, you need all the components. The components are history, exam, medical decision making. So for an inpatient progress note, I need medical decision making, and then I can either have the exam or history fit for that note. So for interventional radiology, The medical decision making is easy to hit for this 99232. And then for my exam, I only need two things. And if we can remember back to the physical exam chart for organ systems under constitutional, if I have 3 vital signs, that counts as 1 organ system. So Epic will auto-populate the organ system. Now all I have to do is one thing on the physical exam category. Typically under skin, I'll say for an abscess drain, for example, I'll say drain side is clean / dry / intact. Drainage continues to be serosanguinous. And that hits my physical exam category. So on these inpatient follow-ups for abscess drains, all I've got to do is look at the drain entry site, make sure the vitals are auto-populated, and I've checked that box. So a lot of people feel overwhelmed that they're going to have to be doing 12-point physical exams on these patients, pulling out a stethoscope and a reflex hammer, and that is just not the case. And again, when we look at inpatient progress notes, most of what you're going to be billing is the 99232. Inpatient consults, there are 5 levels. And when do I bill inpatient consults versus hospital day 1? Kind of already touched on this, but like for example, if I have an inpatient kyphoplasty, I will go up to that patient and I typically spend quite a bit of time with them and talk to them about conservative management in lieu of the kyphoplasty procedure. So if I go and I see a patient and I don't feel like it's obvious that they need the procedure, or there are a bunch of different options I could pursue, then I'll bill that as a consult. But it's up to the interventional radiologist's discretion as to whether or not to use these consult codes versus like a hospital day 1 or admission H&P code. If it's the first day you're seeing him in the hospital, I think just use common sense. Briefly on discharge codes. So let's say I do a lung biopsy, I drop the lung. That's typically a scenario where I just put the patient on my service overnight. I remove the chest tube the next day and discharge the next day. So if I do the discharge, then I can bill for hospital discharge. And in my note, it's very simple. All I say is patient was seen and examined on the day of discharge and it took 45 minutes. And so then that statement will qualify me for that billing. And so I'll get RVUs, work RVUs of 1.9. I want you to know this chart's in the book, and when do I bill ER specific codes? And there are 5 levels of ER codes. And the important part about ER codes, there is no time component, and you have to have 3 out of the 3 key components. So if I have a patient that comes in, let's say the G-tube fell out, it's a Saturday, I'm busy, I don't have any room in my IR lab to add stuff on, I'll go see that patient in the ER. I'll just put the G-tube back in bedside, inject some contrast, get a radiograph afterwards, and patient goes home. So the key to that is patient comes in the ER and leaves the ER. The patient's never admitted. So in patients that come into the ER, I go down there and see them, they never get admitted. That's when I fall back on these ER codes. And the rules are all the same as our other codes, but I want you to know it's there in the book, and this is when I would use it. These are the critical care codes. They kick in at 30 minutes. And so when do I, as an interventional radiologist, use this code? Well, I'll circle back to the same example I keep popping on, and that's you got a uroseptic patient, needs a nephrostomy tube. If I have to go up to the ICU, put in a triple lumen, evaluate airway, bolus fluids, and try to coordinate getting that patient more clinically stable, if I'm up there for more than 30 minutes, I'm going to bill that time as critical care. And another important thing to realize is, like most of these codes, the intensivist can bill this code, I can bill this code. As long as we are different specialties, each provider can bill this code. Briefly, observation services, initial observation services, I rarely ever bill these, but there's 3 levels, just like there are for the hospital day 1 or admission HPs. Subsequent observation visits, again, this mirrors inpatient progress notes to a T. Same day observation, admission, and discharge. Again, as an interventional radiologist, I just don't stumble on to ever using these codes. Discharge, observation, care. So if you put in a patient in OBS overnight, then you would bill this 99217 on discharge. Again, I rarely use these codes. quick thing about residents and mid-levels. If you have residents in your practice, you as the teaching physician, how I have it set up, I have residents in my practice. The residents round on all the patients, and then they present the patients to me, and then I with the residents go and we re-round on all the patients, just like you did in your internal medicine days or your medical school days. And for me, it's a good time to individually get to know the residents and to also teach them the clinical practice of interventional radiology, which is so important. If you have a mid-level, you do not have to round with the mid-level, but if the mid-level rounds on your patients, you still go round on all the patients, and then you can sign on top of their notes. We have tried to implement mid-levels for clinical rounding, and I myself just prefer to go see the patients myself because they're my patients, my responsibility. And so I do not use mid-levels in my practice. A lot of people ask that. I use mid-levels for procedures. Couple scenarios to highlight common things that we see as interventional radiologists. So let's say I've got a post-biopsy pneumothorax that needs a chest tube. So I'm going to put the chest tube in, and I'm going to admit that patient. Again, this will be a modifier 25. This would end up being a 99222 level 2 admit. So when I look at my medical decision making, I'm going to need 3 problem points, 3 data points, and moderate risk. I'm only going to need 2 of the 3 to level the medical decision making. Well, let's look at my patient. As far as diagnoses go, I need 3. So this is a new problem with workup. That's 4 points. That already gets me above my 3 points I need for problems. And then let's look at risk. This is an acute complicated injury, which automatically qualifies it for moderate risk. So then I have the medical decision making necessary for the code of 99222. So my exam and history need to reflect 99222 leveling. So I need a comprehensive exam, which is 8 organ systems. And then I need a history that's comprehensive. So in the HPI, I need 4 HPI points. I need 10 review of systems, and then 2 things from the PFSH category. Next scenario, this is very common. I put in an abscess drain. This is my 99232. Again, as an interventional radiologist, this is a code that you will frequently use. And you need the medical on these inpatient follow-up codes, 99231 through 99233. Again, they deviate from the other codes in that once you get a medical decision making, you don't have to have an exam and history that match that. You only have to have one or the other. So in my mind, I just do a moderate medical decision making for the 99232, and then I have an exam that matches that. And the exam for the 99232 is expanded problem focused. So again, it ends up being 2 organ systems. So for the medical decision making for the moderate category, let's look at this. So diagnoses. If I have a patient that has an abscess drain placement, typically they already have 3 established stable problems. So hypertension, diabetes, high cholesterol, pancreatitis, or whatever. And so for a diagnosis standpoint, established problems which are stable, I got 3 of those, so then I have my 3 problem points. If I look at data, or I could do data. So if I look at data, if I review the labs, that's a point. If they have imaging that I review, like a chest x-ray or an ultrasound or whatever, that's 2 points. So that's another way to get 3 points on the data. But again, for the medical decision making, I only need 2 of the 3. So I can do diagnoses or data. And then risk, which I typically will always do. An acute illness with systemic signs and symptoms, that's moderate risk, right? You have a patient that has abscess drain, they have elevated white count fevers, so that's systemic signs and symptoms. Then your risk is moderate. Now I've established the moderate medical decision making. Now I just need an expanded problem focused exam for the 99232 code. So that's 2 organ systems. So again, for constitutional, the vital signs will count. And then like I had said before, for skin, drain site clean / dry / intact, drainage is serosanguinous. Then I've hit all the high points and documented what is necessary for that 99232 code. We're going to do another one, a kypho consult. So again, I told you for these inpatient kyphos, I'll typically bill a level 4 consult because in most of my kyphos, I try to talk them out of it and discuss conservative management as an option because I think it's a viable option. So medical decision making, again, and I'm not dissing kyphos. I like to do kyphos. I think they are very good for patient care. I do a lot of inpatient kyphos for pain management. But what I'm saying is when I go in and I consult the patient, if I have a patient that says, hey, I'm 92, I don't want to do kypho, I just want to do conservative therapy, I will set that up. I am completely okay with that. So On this level 4 consult note, medical decision making is moderate, so I need 2 of the 3, right? So I start with risk. A compression fracture is acute complicated injury, moderate risk, boom. So then I need diagnoses, I need 3 points, or data that's 3 points. So compression fracture is a new problem with additional workup, so that's another way to get the other 3 points. Or data, right? I review labs, that's a point. I review the MRI and I render an opinion. I say I independently reviewed the MRI, which shows a 20% anterior compression fracture of L2 without retropulsion. That gets me 2 points. So that's a way to get 3 points. Then when I look at the 99254 code, I've got to do an exam and a history that fits with that code. So my exam needs to be comprehensive, 8 organ systems, and my history needs to be comprehensive. So 4 points on the HPI, 10 things on review of systems, and 2 things on PFSH. Fourth thing, again, this is a septic nephrostomy tube. We've already kind of discussed this. And all I'm saying is on this one, this is where you could potentially bill 30 minutes of critical care time. If I'm in the ICU trying to stabilize this patient, then that's a case where I would bill 99291, which is 30 minutes of critical care time. And if I do a nephrostomy on the same day, I'm going to modifier 25 that. Questions. So thank you for watching the video. I appreciate it. I really want every interventional radiologist to go out there and to do more E and M coding. I feel like we are already doing the work. We just need the information and the resources to be confident to go ahead and do the billing. And if you have any questions whatsoever pertaining to inpatient E and M, please put it in the questions comment on the YouTube video, and I will try to reply back and answer your questions. Most of us will probably have the same question over and over again. So by doing this, everybody can have access to these questions. If you like the video, please hit the like button. If you like the channel, please hit the subscribe button.